Hi, my name's Shannon Weinman, and this is my presentation for epidemiology. So the journal article that I'll be evaluating is titled The Recurrence of Cardiovascular Events in Patients with Type 2 Diabetes. It was published in the journal Diabetes Care in December of 2018. Type 2 diabetes is a disease on the rise, and physicians and pharmaceutical companies are working to find effective and safe treatments. On a personal note, I work as a research monitor on two type 2 diabetic cardiovascular outcome trials, so I decided to choose an article that would align with my work. Although the article is older, being published in 2008, and the study itself spanned from 2000 to 2004, it does give a great look into the data behind the need for such cardiovascular outcome trials. So the background for this study, according to the article, the reasoning behind the study was to help clinicians prevent cardiovascular event recurrence. As type 2 diabetic patients are at a higher risk for cardiovascular events, the data behind how and when these types of patients have recurrent episodes is a tool that would help clinicians to treat type 2 diabetic subjects. The Framingham Heart Study is a great tool that helped to provide some of the background information for this study. The Framingham study determined that the risk of recurrent myocardial infarction is higher for diabetics and is especially higher for diabetic men than diabetic women. According to this article, let me get to the next slide. So the objective of this study, according to the article, was that the purpose of this study was to assess incidence of and risk factors for recurrent cardiovascular disease, also known as CVD, in type 2 diabetes. As already discussed, the cardiovascular risk with diabetes is a topic that is increasingly relevant as the incidence of diabetes continues to climb. This study was an observational cohort study conducted in Italy. There were two cohorts, A and B. Cohort A was comprised of all subjects that had a cardiovascular event prior to enrollment. Cohort B was comprised of all subjects that had a cardiovascular event during the course of the study. As I noted, this study was observational, it was not interventional. So the study lasted 4 years in order to collect enough cardiovascular recurrences, or in the case of cohort B, initial cardiovascular events, to provide significant statistical findings. There was a total of 14,432 subjects. I just realized that I have a misspelling there. There we go. So 14,432 subjects enrolled and observed during the trial period. As previously discussed, cohort A was made up of all subjects who had experienced a cardiovascular event, such as myocardial infarction or coronary artery bypass grafting, prior to their enrollment. All subjects who had never had a cardiovascular event were observed, but were not placed in any cohort. Cohort B was developed during the course of the study and included subjects who had an initial cardiovascular event during the study time period. All subjects that did not enter cohort A or B were not included in the data for final analysis. For recruitment, there were 157 diabetic clinics used throughout Italy. They recruited from their already existing clinic patients. The study required that the subjects be type 2 diabetic and between the ages of 40 and 97. Now, I'm not sure if the 97 was an actual inclusion criteria or if they're just paraphrasing the actual ages of these subjects. There was no defined exclusion criteria with this study, or at least was not noted in the article. The sample size, they did not mention any sample size statistics. In other words, the article did not present any statistics as to how they determined what sample size they were going to need. However, 14,432 total subjects were used, so it was quite an extensive study. In the initial enrollment period, 2,788 subjects were identified as having a previous cardiovascular event and were placed in cohort A. After 4 years, the investigators had identified another 844 subjects who experienced an initial cardiovascular event and was placed into cohort B. All of the data was collected by the 157 diabetic clinics that were initially used for recruiting, so they all followed their own subjects. The statistical analysis was performed separately for cohorts A and B. The variables that were used in the analysis were those collected at enrollment for cohort A, and the follow-up visit after first CVD event for cohort B. The data was analyzed first with mean plus or minus standard deviation for continuous variables, median or interquartile range for non-normal variables, and proportions for categorical variables. Both a univariate and multivariate Cox proportional hazards model were used for risk factors of recurrent events. The covariance for the univariate model is lengthy. It was BMI, total cholesterol level, HDL cholesterol, triglycerides, A1C, blood pressure, alcohol intake, smoking status, familial CVD criteria, microvascular complications, lipid-lowering treatments, antihypertensive treatments, and treatment for diabetes. Of note, this criteria was collected via surveys at the initial visit or the visit following initial CVD event in the case of cohort B. Additionally, an evaluation for the interaction between blood pressure level and antihypertensive treatment and between cholesterol level and lipid-lowering therapy was performed. So for the results, in cohort A, 414 subjects developed at least one recurrent event, and of note, one subject had 3 recurrent events. In cohort B, there were 54 subjects that developed at least one recurrent event. And the average time between enrollment and CVD event in the case of cohort A, that would be a recurrent event. In the case of cohort B, that would be their initial CV event. For cohort A was 1.6 years plus or minus 1.04 years, and for cohort B, 1.5 years plus or minus 0.8 years. This slide shows the results as displayed through standardized incidence. The study did note that the most common CV risk was hypertension amongst all subjects. In cohort A, where most of the data was collected, it showed that subjects, again, who were older, male, and had a previous history of microvascular complications and used insulin and lipid-lowering medications. Now, this is not all concurrent use. Each of these risk factors individually did show an increased risk of CV event recurrence. So any of these risks or any of these risks concurrently did increase risk. Again, with the results, the percentage of subjects in cohort A that had a recurrent CV event was 6.1%, which the authors of the article did note that it was comparative to other studies that was out there, so that was very nice being able to see the reproducibility. The 2 studies that they referenced were the ProActive study and the Scandinavian simvastatin survival study. Both of these studies showed 5.9 to 6.0%, so right in the ballpark there. Additionally, the incidence rate of cohort B was almost half that of cohort A. However, there were more women, younger subjects, and less familial CVD present in cohort B, so the risk factors themselves were lower. And as discussed on the previous slide, these were all risks associated with increased recurrent CV events. Finally, high cholesterol and triglyceride levels were found to have some type of causal effect on increasing the incidence of recurrent CV events, as noted by the article authors. The authors were quick to point out the clinical practicalities that emerged from this study. Based on the analyses, the article authors feel that older men with CV onset of myocardial infarction or revascularization should be closely followed up by their physicians. Second, patients using insulin showed a slightly higher frequency of recurrent events, so these types of patients should be followed up closely as well. And of note, the authors do point out that the connection between insulin and increased frequency of recurrent events should not be taken as causal as of yet, since the patients that are insulin dependent tend to be in poorer health than those who are taking oral antihyperglycemics alone or are not taking any pharmaceutical treatments. Third, diabetic patients with high triglycerides should be targeted by aggressive treatment following their initial CV event in order to reduce the likelihood of a recurrent event. After reviewing this article, I found that the main bias that the investigators may have trouble with would be recall bias. So, as so much of the study design is based on subjects accurately reporting whether or not they had a previous CV event, the results could have been unintentionally biased based on the subjects not recalling a previous CV event or inaccurate reporting that they had one. The example that comes to mind for me is that of a TIA, a transischemic attack, being confused for stroke. So these two events are not the same thing, as a stroke is considered an IHD or an ischemic heart disease event. That's classified through the study as a major IHD event rather than a minor IHD event, which did factor into their statistical analysis. However, if a subject coming into the study said they had a stroke in the past and were immediately put into cohort A, but it turned out that they actually had a TIA instead of a stroke, they may have been misstratified on that. So the conclusion of the investigators, it appears to be in line with other studies. They mentioned some through their results section, and the study was a good example of classic data collection in order to better understand medical risk. However, studies, preferably randomized trials, will need to take place in order to test out any therapeutic measures that may emerge from this study and others like it. And here's just a list of my references. The top is to the actual article itself, and the other two are for the two studies that were mentioned throughout this presentation. Thank you very much.